time, I believe you. Is everybody ready?
Yep.
Yes.
Great. I'm so excited about this. As you know, this is our first launch of the webinar from All's Possible, and we are delighted. We decided to start with this topic because, as most of you know, we started a discussion board for caregivers last year, and this was the topic that got the most input. And also because one of our caregivers, Mr. Costin, offered some insights that seemed so useful that we really wanted to share them with a larger audience. So you'll see that what I'm going to talk about today in my slides is really a combination of what Mr. Costin offered in the discussion board, and you can read what he had to say also in the newsletter, and some information that came from the AHRQ website that we're going to talk about in a minute in terms of additional resources. And I really hope that you all will enjoy this format, and we're going to, of course, be seeking your input for how we're going to be doing this in the future. But we think it's really important, first of all, to make sure that we hear from caregivers, because really so much of this information is all learned by trial and error. So these folks really are our experts, and so we want to maintain that focus. And also the importance of addressing a topic from multiple angles, because there are so many people who are involved in one individual's care, and everybody has a different way of looking at it. So I think that this is going to be a helpful way to do that. So again, we're seeking your input on that as we move through. So our topic, obviously, for today is communicating with your physician. And like I said, the things that I'm going to talk about are a combination of what Mr. Costin had to offer, as well as some information from the AHRQ website. So, there we go. Okay, so I really just have I have 7 points, but 3 on this first slide in terms of communication. One of the things that come from both of these sources is the importance of clarity and preparation, and making sure that you come to your physician's visit, or any healthcare provider for that matter, with a prioritized list of concerns that you and your loved one have come up with together. And I emphasize prioritized here because, you may have 18, 27, 140 concerns, but those are going to be more than you can address in one visit with your physician. So you want to make sure that they're in a prioritized list so you're able to address first things first. The second topic is about listening and speaking. And sometimes people think that it's off-putting to take notes when you're visiting with your physician, because they think, my physician is going to think that I'm, going to share this, and I'm, really going to be persnickety about what I'm writing down on my piece of paper here. But, I think in actuality, what it says is I'm serious about my care and about the care of my loved one, and what you have to say is important, and I want to make sure that I get it right. And it's truly a demonstration of individual compliance. And, if you don't feel like you have the rapport already established, you may want to ask if it's okay if you take notes. In fact, I always think that that's a good idea to, say, do you mind if I take notes? And you may want to say what you say is important to me. And remember that good care is all about building a relationship, which, of course, leads us to our number 3 point about communication, that we're all in this together. And as our mothers and grandmothers taught us, you get more flies with honey, and sometimes things get really sticky, and it's important to remember that this lesson is true in every relationship that people have. One of my good friends is an elementary school teacher, and she uses this second concept, which is called glow, grow, glow, in giving feedback to her students. And I really think that it's a nice approach in all kinds of relationship building. That sometimes when things do get sticky and you may want to have some unfavorable feedback to offer in your visit with your physician, maybe you want to say something nice before you say something harsh, and then wrap it up with something nice. And, these things seem like really elementary kinds of concepts, But when we're in situations when either we are sick or we're stressed out by the care that we're providing for someone else who is sick, sometimes we forget these very simple key concepts to how well, how we really get along well with other people. Okay, so moving on to our next slide. There we go.
I have a question real quick. The music, is that part of, does anyone else do that?
I'm sorry, I just sent a message to everyone. Someone placed us on hold and we're hearing their music in the background.
Oh, okay.
Oh, is that what that is? I wondered.
Yes, it's not.
I thought it was just playing in my head. I'm glad you all hear it too.
I'm terribly sorry, but I sent a message to everyone hoping that whoever placed us on hold will remove the hold.
Okay. Well, hopefully it will stop.
Okay.
Pretty nice music.
Yes, it's lovely. It's lovely. Okay,
it's not by design, it's by accident.
But it's good it's not worse.
Okay, point number 4 in terms of communication and advocacy. Something to keep in mind is the fact that most healthcare professionals do not have formal geriatric training. And this is something that you want to make sure that you find out about your care providers. Check into their training and their expertise, and if it turns out that your care professional, your primary care provider, doesn't have formal geriatric training, but you really like this person, I'm not suggesting that you go out and seek another provider, but maybe you want to seek support professionals who do have geriatric training. It's very important that you get to know your pharmacist, that you only have one pharmacist for all of your medications, and that pharmacist has geriatric training. And the same with other care providers, your occupational therapist, your physical therapist, your social worker. But just to keep in mind that just because a person is a healthcare professional, that doesn't mean that they've been trained in geriatrics. Wrap-up and follow-up relates also to the point about taking notes. You want to make sure that whatever whatever your care provider tells you, that of course you write it down, you take it with you, you rephrase that information, and you follow up in whatever way you feel like you need to follow up. Let the person know, this is what I'm going to do following our visit, and these are the things you said that you would do. And again, that's part of advocating for your own care and the care of your loved one. Number 6 is seeking referrals if you're not satisfied with your care. Don't wait around and think that it's going to get better. If you are not satisfied, you want to make sure, again, that you're advocating for better care. Sometimes people say, well, I don't want to complain. This person is fine. I may not be able to get any better care. It's going to be so much trouble to find another care provider. But really, it is in your best interest not to wait around and think that it's going to get better. And, of course, these are all tied up into making sure that we all advocate for our own care, but also the responsibility of educating others. Now, there are lots of ways to educate others, and some is just about complaining. But really, that's not the point, just to say that I'm not getting the care that I want, but to help others seek new ways to find better care and advocate for their own care. And then finally, some other things that I'd like for us to think about in terms of other issues. We talked about the importance of finding other support professionals. Elder care is best provided when it's provided in a geriatric interdisciplinary team. But that's not, always the way it's done. We talk about it as the ideal, but it's not necessarily the way it comes about, on the day-to-day basis. So in creating your own interdisciplinary team, you want to make sure that while your primary care provider is at the hub of that care, that you have support from other sources. I already mentioned your pharmacist, if you have other therapy support individuals, and also community agencies that are available, the Alzheimer's Association in your area, the Area Agency on Aging. We're very fortunate in Virginia to have Senior Navigator, and that's an excellent resource. And other community agencies like Jewish Family Services or maybe your Community Services Board, there are lots of those support services out there to help you create your own interdisciplinary team. The second point in terms of other issues refers to demanding geriatric training in your care providers. Like I mentioned, this is not a given. Just because a person is a health professional does not mean that they have geriatric training. And in order to be certain that that person knows about the issues that you're dealing with, you want to make sure that this is part of their training. And as our elders, of course, become more savvy, this is going to be a requirement, and people are going to be demanding this. And then to be certain that we are educating against ageist attitudes. The example that I gave in the newsletter was, about a joke that my grandmother used to say when she would go in and see her physician, and her physician, she would say, well, why does my knee hurt so bad? And her physician would say, well, what do you expect? You're 80 years old. By the way, she just turned 96 yesterday. But he would say, what do you expect? You're 80 years old. And she said, well, my other knee is the same age, and it doesn't hurt. Well, just because you're old, it doesn't mean that you should be in pain, and it doesn't mean that you should be sick, and it doesn't mean that you shouldn't be able to be independent in many, many ways. So don't accept those attitudes, because it's our responsibility to stamp those out and to, again, advocate for our care. And a part of that has to do with those ageist attitudes that many people fall victim to, including our healthcare professionals. This next slide lists some resources, again, from the AHRQ website. And just one of them that I want to point out to you is the Question Builder. I thought this was an excellent resource. Of course, this is an excellent website from the Agency for Healthcare Research and Quality. But this one has, for people who say, well, I really don't even know where to start with creating my own questions or what I need to ask. This section here allows you to go through and say, these are some things that I want to make sure I ask, and they kind of prompt you, and so you can create a list, and, from the list that they have provided, what is my diagnosis, and what's the technical name of my disease. Sometimes just having questions to ask means that you will get answers, because if you don't ask questions, your care provider is going to think that you know the answers, and that may not necessarily be the case. Okay, so this is just an example of one of these resources. And, of course, these resources will be here after this seminar, so you'll be able to come back and check these out. Okay? So that is the end of what I wanted to share, and I think we'll either kick back to Nico or kick over to Russ.
I think that we should just take one of the questions that we had from Christy. And Christy, if you want to pose your questions, I had just sent it out via chat, but if you want to repeat it.
Well, sure. This is from personal experience because I'm close friends of someone who is suffering from dementia. And initially when she was diagnosed and she had gotten medicine and treatment and follow-up appointments with different providers of care, and then it sort of fell off in the family. It's almost like they're ignoring it or denying it. And I have given her lots of the resources that I felt I should give because of my knowledge. And but it's sort of like they're just blowing it off, and they're just sort of ignoring her treatment, and she has since stopped taking the Ariza, and it's her memory's getting worse, and my mom and I are very concerned, and we want to know, how do we intervene? How can we talk to a doctor and have, how do you bridge that gap? And I don't want to offend the family either, I don't know if they really are doing a good job, but it just doesn't look like it.
Right. Well, I think that's a tough one, Christy, because, certainly you want to offer all the resources that you can because of your expertise and because of your interest, and your concern. But I think that's really all you can do is offer resources and offer your concern in a way that isn't intrusive. At some point, sometimes people only want to know what they want to know, and they only want to do what they want to do.
Mm-hmm.
And that sounds so simplistic, but and at the end of the day, you just have to know that you did the best that you could.
Yeah.
I think that's a tough one. And does anybody in the group have something to offer? Because I think that's something that we've all encountered.
Yeah. Well, I would. This is Russ Swerdlow. I would just, that's. Hey guys. It's a tricky one. There's two issues here. One is the medical issues, which especially if there's medical noncompliance because the patient has Alzheimer's and needs assistance with the treatment plan. The other issue is a social issue, and the worst case scenario with the social issue is that the patient is not really getting all the support that she needs and is not safe. And Anne's exactly right. I mean, you have to be very, very delicate in the way you approach this kind of thing because you're stepping on other people's toes. But on the other hand, you don't want to just let it slide. So things you can maybe talk about are offer to go with the patient to her next physician's appointment, so that you can give a little more background as to how you see things are going on, and maybe maybe it's not so much a thing for the physician to solve from a medical perspective, in so much as to try to address from a social perspective, such as, do you need a social worker out there? Do you need someone to come out and just see whether things are safe in the home? Sometimes those can be a wake-up call to the family. In the worst case scenario, where the patient really isn't getting appropriately looked after, then it becomes an issue for Adult Protective Services.
Right. And that's what we're kind of on the fence about. I know about JFS and they have them, people like that who come out to your home and are able to assess, but how does a friend or can a friend of the family talk to JFS and have them contact them? But then they would know, the family would know that we went over their heads. Or if you're allowed to do something like that, or
if there's I think if you can do it without going over the family's heads, that would be preferable.
Right.
But there are also issues too if you think that the patient is in harm's way.
Right.
And no one's doing anything about it. That also puts you in a difficult situation too.
Mm-hmm. And I would suspect that most APS reports come from outsiders who feel like they're in that same situation and just want to raise the issue and have somebody take a look. I think Russ is right. It's delicate, and you have to weigh that. Is this person in harm's way?
Mm-hmm.
And also, Christy, I think a lot of the APS reports can be done anonymously.
Yes.
Do you tell APS you don't want your name used, and they won't?
Mm-hmm.
And also, I don't know if it's Alzheimer's or not, but I know that the Alzheimer's Association here in Richmond, Mary Ann Johnson is really good in talking with families, in acting almost as a mediator, trying to convince people that your mother does have dementia, she does need further assistance, and letting them know what to do next. So, but the only catch there is somebody in the family has to be the one to call Alzheimer's.
Right. I've given them the Alzheimer's Association's numbers and websites. And
is there anybody in the family that would call Alzheimer's?
Well,
a cousin or anybody?
Possibly. The person who was initially dealing with her care is her daughter, and I've grown up with her. And but she has her own 2 young children that she's trying to take care of. I think at times she feels overwhelmed. That sandwich generation feel. But So I guess I could just keep talking about it, and I guess that's all I can do.
May I interrupt for just a second? There is someone who has us on speakerphone, and there's some sort of a noise, background noise. So if you want to mute the line, just press 6, and if you want to unmute, press 6 again. There's someone talking in the background that sort of covers us. Okay, I don't know where that's coming from, but anyway, should we now pass the ball to Dr. Swerdlow, who is an associate professor at the University of Virginia in the Department of Neurology, and he'll be giving us the physician's perspective. So take it away.
Well, thank you, Nico. Thank you. And let's see here. If I can, there we go. Okay. So the analogy I'll give you, folks, is sort of like the analogy between medicine and a restaurant. And I'll tell you what sort of goes on in the kitchen. And hopefully, at the end of this, you'll still be willing to eat at the restaurant. But basically, Alzheimer's disease is one of the toughest diagnoses for a physician to make. There are a lot of reasons for that. One is that it's really based a lot on the reporting, sometimes of multiple informants, and sometimes we hear slightly different stories. Especially if things are subtle. Well, we don't live with the patient, so we can't really. It's really up to us to sort of put that within a frame of reference that we sort of see. And that frame of reference may be, this is pretty bad, or this isn't so bad. Sometimes it's hard to know, especially when we don't really know what the baseline of the patient is. The other reason is that in 2007, any kind of diagnosis that has big implications, like a diagnosis of cancer or diagnosis of Alzheimer's disease, or anything other than Alzheimer's disease, there's really a test for. What we do is we get someone else to make the diagnosis for us, and that takes us out of the line of fire. So it's not like, hey, we diagnosed you with cancer. It's like, hey, the pathologist looked at the biopsy and made this diagnosis of cancer. Or, hey, we got the MRI scan and we saw this, and the radiologist made the diagnosis. So this is basically one of the last bastions of clinical impression, where a physician basically has to take the time to listen to the story and do an exam and put everything together and using their best judgment, determine is this Alzheimer's disease. And that's intimidating to a lot of physicians. It can be tricky, and we like to be able to have other people make these heavy diagnoses for us, but with Alzheimer's disease, it's still just kind of up to us. It's up to the physician. Okay. What about, so I mentioned the history and the exam. Let me talk a little bit about the history and the exam. So, there's, for the physician certainly who's trained to pull out the salient features of the history, there's a couple of main things that we want to sort out. One is that, assuming that there's a problem there, and obviously there's a problem there, that subjective problem that people feel is enough of a problem to talk to us about, or to want to talk to us about, we'll cut people some slack up to the point that their activities of daily living are being impacted. So it's one thing to get the story from an 80-year-old that hey, I'm not as sharp as I used to be. But it's a very different thing to get the story from an 80-year-old saying, I'm not as sharp as I used to be, and I now can't take my medicines anymore by myself because I get too confused and I need someone else to help me. So, so we'll ask certain pointed questions like, how are you doing with handling your medications? How are you doing with paying your bills? How are you doing with handling your checkbook? We may have to some things we just simply have to talk to other members of the family about, such as, is your mom or dad or sister, brother, whatever, spouse, repeating him or herself too often? Are they having trouble with the driving? Trying to get a feel for what's the depth of the complaint here, and we want to be able to establish that it's affecting the activities of daily living. Sometimes, we actually recognize now that Alzheimer's disease may develop over many years. It may take years to get to the point where we can really where it meets the criteria, and we can say, yes, this is Alzheimer's disease. And there are a lot of people who are sort of in this purgatory where they're not good enough to be what we would consider normal or just age-related abnormal, but they're not enough that we can say that they're demented. And those people will often label mild cognitive impairment. And in many of those people, what we're seeing is just very, 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 very early Alzheimer's that's just too early to really go out on a limb and diagnose. But we will acknowledge that sometimes people don't have activity of daily living problems to go along with their cognitive complaints. Okay, but we can't call it Alzheimer's unless an activity of daily living or activities of daily living are impacted. And from the history, we want to know, how has this been developing over time? Is it something that came on as boom? One day it was there, one day it wasn't there, the next day it was, or is it just something that just kind of snuck up on everyone? Snuck up on the patient, and it's has gradually developed over time and gradually gotten worse and just become more noticeable to everyone. So the onset and the course over time are very important. Now, on the exam, the exam of the person with cognitive complaints can be a very beautiful thing when done correctly, and it could be a clumsy thing when it's done in a clumsy fashion. Most people who go to see a physician will at least get a general exam. They'll get their lungs listened to and their heart listened to. But a lot of people, when they bring up the point about, hey, I'm here because of memory, there'll be no examination of memory done. Can you imagine going to a physician complaining of a cough, and you get sent out of the office without the physician listening to your breathing with the stethoscope? Well, that sort of happens all the time when the complaint is memory. The physician will still listen to the lungs with the stethoscope rather than examine the memory. But that's a crucial part of the exam. And it could be simple things like, can you tell me what the date is? Can you tell me where we are? And there's a whole host of other things that can be done to sort of try and flesh out the cognitive exam. If the cognitive exam is somewhat unrevealing at the bedside, or if there's not time to do a cognitive exam, or the physician just isn't comfortable doing one, there's always referral to either a cognitive neurologist or a cognitive subspecialist, like a neuropsychologist, who can provide that part of the exam. But you need to see cognitive deficits in memory in at least one other area. And what I mean by other areas, problems with language or organizational abilities or visuospatial abilities, things like that, in addition to a problem with memory. And basically, just to boil it down real simply, if someone is having memory issues and cognitive decline that is developing slowly and insidiously over time, and it's bad enough to affect activities of daily living, and you can see the memory problems and other cognitive problems on the exam, and the patient's walking normally, and they're an older person, most of the time that's going to be Alzheimer's disease. But that's sort of, again, it falls into a lot of, does the physician feel comfortable enough to take the data that he has at hand and synthesize it into a diagnosis and then render that diagnosis. Now, moving on to number 3 here on the slide, other evaluations. And I think the physicians will sort of use the other parts of the evaluation sometimes to buy time, which is fair and reasonable. The families, I think, will often focus on the tests because we love technology. and we want big expensive tests or even cheap tests to make the diagnosis for us. The person that is suspected of having that appears to have a dementia, whether Alzheimer's disease or another type of dementia, should have certain blood tests done. And these are all guidelines that physicians work under. The blood tests include things like blood counts, blood chemistries, liver function tests, tests of the thyroid, and a vitamin B12 level. And hardly ever do these tests actually change the diagnosis. But we have these guidelines, and we should check these blood tests. And then brain imaging. Well, the guidelines also suggest that if we feel someone meets the criteria for dementia, whether it's due to Alzheimer's or any other cause of dementia, we should get pictures of the brain, either a CAT scan or an MRI scan. And people will often put a lot of credence on what the imaging shows. The imaging really is to rule out alternative causes of cognitive decline, like big strokes or tumors. Usually, based on the history and exam, we should know whether something like that is going to be present or not. But the guidelines are that we get an imaging study. There are some other choices that we can choose from, like neuropsychological testing could be extremely helpful in helping to establish the diagnosis. There are things like PET scanning, which, we can talk later on about when you would get a PET scan. I mean, usually these high tech things don't make or break the diagnosis. They're far less important than getting a clear story and a good exam.
The bottom left. There you go.
Okay, here we go. So, we've listened to the story. We've done the exam. We've done the blood work and the imaging study. We've rendered a diagnosis. Let's say the diagnosis is going to be Alzheimer's disease. There are a number of things that I like to discuss with the patients and the families, and that I think are important to touch base on. One is expectations. We'd like to be able to cure this, and we can't, and we need to be frank about that. But there are some things that we can do that can help. We need to talk about how much they might be able to help, and that could be the difference between the family coming and the patient coming back to a follow-up visit being very upset because they still see these big problems present versus being very happy because they see the subtle changes for the better that they were told to look for. But we do need to stress the fact that this is a progressive problem, in that even though we may be able to slow down the decline or even temporarily improve it to a subtle degree, that eventually it's going to get worse. I touched a little bit on the drug treatments. So, the drug treatments can be of some benefit. The drugs fall into two main categories: those that increase the levels of a chemical in the brain called acetylcholine. Those medicines are the Aricept, Razidine, and Exelon, and then a drug called Namenda, which works through a different mechanism. And certainly in my practice, I offer people these medications because they can help to a small degree, but I have to be realistic and forthcoming to the patients and the families about how much help from the medications we can expect. But it's what I would do for my parents if they were so diagnosed. Treatment for behavioral problems. Now, behavioral problems are a big issue. It's the behavioral problems that will often drive people from the home. The caregivers can often deal relatively well with amnesia, with loss of memory. What they can't deal with very well is the confrontational, combative, in-your-face spouse. I mean, I have enough doing that with mine, and she's not demented. The first thing that we want to try and do is try and determine is there some non-medication approach we can take to the behavior. For example, a lot of times when patients are agitated, or irritable, they may be uncomfortable about something. They may be in pain. They may be hungry. They may be depressed. If we can sort of recognize what's pushing people towards these behaviors, sometimes we can rectify the behaviors without a treatment or without a medication treatment. It's usually better if we can have success with a non-medication approach. And the reason is that we don't have any magic bullet medications that fix these behaviors. So sometimes when we are really pressured, we will use medications that are used to either sedate people or to quiet people down, so to speak. Antipsychotic medications that are used to treat things like schizophrenia. We'll use those. We used to use them. We used to have a lower threshold for using them. Lately, you've probably heard a lot in the press about that. Well, two things. Number one is that these medications don't have tremendous efficacy, although sometimes they can help. And as with all medications, they can have side effects. So if the medicine isn't going to be helping, or isn't going to be helping that much, you want to ask yourself, is it likely to help more than the side effects that may result? And then finally, advice on relevant social issues. So a lot of these things, I'll touch on very briefly, but some of them, for more discussion, may be better done by other professionals such as social workers or lawyers. Issues about driving will come up. Patients need to know that, especially if they're still in relatively good shape and they can participate in decision making. They should make it clear what they want their medical directives to be in case they are seriously ill in the future. It's time to update your will. Issues of where to live, down the line. It's probably best faced while the patient is able to participate. And the Alzheimer's Association is always a great source of support and information that people need to know about because they can benefit from being tied in with them. And that brings me to the last slide, which is just titled Other Issues. And that is, we recognize that, I'll just say that Alzheimer's is particularly tricky for the physicians because the patient isn't the only patient that they're dealing with. Sometimes, I find myself dealing more with issues that are more pertinent to the caregiver than the patient. The caregiver is an essential part of the total bigger picture illness. And it's important that the caregivers don't burn out and that they take care of themselves, and that's where the issue of respite comes in. And so for caregivers that feel like they just can't handle another day, another moment, that's time to figure out ways to get more help or to take a break. And the other thing is that despite no matter how much we want to help, we can't. In 2007, we can't cure this, and it's frustrating. It's frustrating for the family for the patient, for the family members, and for the doctors as well to see a patient that we can't make this better. And this is a major issue for our country, and we need to we need to all be I would say that for those who are angry, if you're looking for a place to displace your anger, do it in advocacy. That's ultimately the only way that we're going to really make this really fix this problem. is by having our as a nation just decide that we need to really look into fixing this kind of problem for once and for all, and that'll be done through advocacy, advocating for more research. So I'll stop babbling at this point. And,
fantastic. Thank you very much, Russ. Why don't we open for questions, and then maybe Anne can tell us a little bit more about future topics of our newsletter and live discussions. So any questions at this point? Comments, suggestions, resources?
Hello?
Yes?
Yes, I wanted to just mention, it's Eileen from the Alzheimer's Association.
Yes,
just
Eileen.
Wanted to mention that AHRQ is a wonderful resource. Another one is CareFinder. Has anybody tried that?
I haven't been there in a while, but you're right, that is an excellent one. Nico, can we add that to the newsletter resource?
Absolutely.
Terrific. It's, at alz.org and just one click, and it does help you to recognize what quality care would be and plan and pay for it, but I think the most helpful aspect is what we've done a lot of with the helpline is to help people frame the situation by asking them questions and letting them answer those and then print out the recommendations. I think it's actually in the framing of the issues that the person who is the caregiver or has a loved one with dementia is able to get a better handle on the situation. And that's a good basis for planning. Thank you.
Yeah, that's an excellent, because really I think the expertise of people who participate in the helplines, just listening to those stories and being able to offer that is such an invaluable service. Thank you for bringing that up.
Oh, you're welcome.
Any other comments, questions? Remember just to unmute your phone if you had pressed 6. Just press 6 again so we can all hear you.
Yeah, I think this is exactly what we're hoping will happen, that we can have this opportunity to just share and learn from each other, because I think at least what Nico and Russ and the rest of us who are involved with this education core as part of the Alzheimer's Commission, the opportunity to help people steer towards the services that are already in existence, not to recreate anything that's anything new, but just to direct people to the right places, which of course is the Alzheimer's Association and other services that already exist.
I think we're also fortunate to have Bob Schaefer with us. Bob, can you hear us?
Yes, I can. Can you hear me?
Yes,
Excellent.
fantastic. So we were all hoping that you could join us today because you're always a fantastic resource and you have, all this experience that you can share with us. So anything that you can contribute or share with us today, that'll be great.
Well, I just came in at the tail end. I was tied up this morning, but just listening to the last comment I heard, I found that over the last 19 years for me, the biggest problem was that nobody ever referred me to any of the services when I went to a physician, and I think that's a real shortcoming. The sooner you can get referred to some of these services, the better your life becomes as a caregiver.
Hey, Nico. This is Janet Schaefer. I have to concur with what Robert said, Bob said, with dealing with my dad. If I had not already been working in the network and know that there were resources available, we would not have been referred to anyone to help out with any of the issues with him as well.
Yeah, it certainly is heartbreaking that, the services are available. Not that there are enough services, but certainly there are resources and expertise out there, and people just aren't getting the word. So we're hoping that this will be another way to, again, direct people in the right direction. We had Russ, as the chair of the Alzheimer's Commission, had some caregivers come to our last meeting and talk about the exact same thing that Bob and Janet are saying, that nobody told them about the Alzheimer's Association, and we just hate to hear that.
This is Julia at MEOC in Big Stone. We found that one of the things that we have to kind of combat is that people don't know about services and really don't look for services until sometimes they're in this very much of a crisis mode. And then at that time, they're just kind of reaching out blindly. So that's one of the things that we kind of work with and deal with every day.
Hello?
Hello?
Hello.
Yeah, go ahead. I'm sorry, go ahead. Hello?
There's still...
Yeah, I think something happened there, but I think we have everyone on. Yes?
Yeah, I think we lost Julia.
Uh-oh.
Oh, no.
I hope she can dial back in.
Well, that was certainly an important point that she was making, that we all need to help better direct people to the services that are available.
Marilyn, I know that you're also on the phone with us. Can you hear us? Probably she just muted us. If you need to unmute the phone, press 6 again. Oh, well, maybe we lost her too. Yes.
Well, would you like to talk a little bit about the future topics?
I thought basically what we have outlined on the slide that we have here, we are presenting our next targets, and we're hoping that you will join us in this combination of newsletter / live discussion / forum. If you visited our website at allspossible.org, we have a combination of an electronic newsletter as well as a forum in a format of a threaded discussion, and which we intend to combine with this live discussion on a monthly basis. So if you're interested to become a discussant in any of these topics, please let us know. There's an email at the bottom of this page. Let us know, contact us, and then we will be very happy to work with you in packaging this kind of a format. And by the way, today's live discussion is recorded, and we are going to place all of our live discussions on the web, free access, and it will be just a very simple download of a Windows Media file. So we hope you will share the links and be part of all future discussions and newsletters.
Thank you, Nico.
Any other questions, comments?
Nico?
Yes?
Yeah, since we're dealing with the topic of communicating with your physician,
please.
I'll make a couple observations that I've learned over my 19 years as a caregiver. And one of the things with physician that I found is that I, as a caregiver, had to educate them about Alzheimer's disease. Unless they specialized in that area, and I wasn't able to find anybody that specialized in that area, so I was dealing with GPs. And it was quite a process to try and educate them to the disease and to the responsibilities of the caregiver. And one of the biggest problems I had, especially in dealing with doctors in emergency rooms, was impressing on them the fact that the patient, depending on what stage they're in, and the caregiver should not be separated. And I ran into that, and the results of it were devastating for my wife, where they separated us and not permit me to go see her. And I think it's an education process on both ends, especially if you're not used to dealing with this particular disease.
Well, that is so critical. You're right. I think that in so many ways, the healthcare professionals are much more novices than the caregivers, and it really is an opportunity to educate each other.
Yeah, and one of the problems that I found that there was not necessarily a willingness, especially on the part of emergency room personnel, to be open to what the caregiver said. Yeah. It got to the point where I had to carry a special letter with me and her power of attorney anytime we went to the hospital, which was frequent because of problems that arose. And I had to present them with a letter that if I was not part of the entire examination process and the diagnosis, then I wasn't going to authorize payment with her power of attorney. And maybe some of that is because of the time frame. This occurred several years ago, and perhaps it's gotten a little better since then, but I'm not sure.
So you said that you took your letter of power of attorney, and did you also take lists of medications? And what other kind of information did you take with you?
Well, what I did was take the power of attorney. I took this letter, especially if we dealt with a hospital or emergency room. I always had a list of her medications with me all the time. And when I got to the point where she developed a little bit of paranoia during the progression of the disease, I used to write down for the physician and the nurse a complete account of what we were there to see them about, so I wouldn't have to talk about her in front of her.
Yeah,
because it used to get her extremely upset if you would talk in her presence about her.
Right.
So I was able to overcome that by alerting to the doctor, alerting him to the problem before we even went in to see him, and he'd come in and treat her for the ailment, and she was very impressed with that.
Yeah, that's very helpful.
On a positive note on the part of the physicians, one of the things that I utilized them for was my wife had great respect for her doctors. And when it was difficult to make a decision about something, one of the hurdles we had was getting her to go to an adult day center. I had the doctor write it on a prescription. Then I hung that on the refrigerator, and that was a reminder for her that, hey, the doctor prescribed this for you, and that helped me to overcome that problem. And that might work for some physicians for driving and other problems.
Russ, have you ever used any of those kinds of techniques or know people who have?
Sure. I would just say that, it never fails to amaze me, sort of the horror stories that I hear about. Yeah, but it's interesting. It's really what Bob's saying is that you have to be willing to improvise. You have to use common sense. You have to be willing to advocate. And part of what I think what Bob realized is that you need to figure out ways to sort of guide things in the direction they need to go in. The physician may have been in a situation where maybe he was yelled at by someone for not separating a person with Alzheimer's from the spouse. I mean, I agree with Bob. I think it's very helpful to have the caregiver and the patient together as a unit, because they really function together as a unit outside the office or the hospital. But sometimes, I'll get yelled at by a family member who will say, how can you make me talk about my wife or my mom or whatever, like that in front of her. I don't want to. Don't put me in a position where I have to do that in front of her. So, I mean, you have to. So sometimes it's not as obvious for the physician what the best way to approach the interaction is. Now, certainly separating a person with Alzheimer's from someone who can actually give the story about why they're there, why she's there, in the emergency room is Bob, that's just horrible. But it sounds like you did you figured out a way around this, and people have to realize that they may have to figure out ways to make things work right. And what works for some people may not work for others.
Okay. Well, Bob, do you have any advice in terms of, we're sitting here talking about how important it is to advocate and make sure we take respite, and these are times when people are really not necessarily at their best. And so we can talk all day long about how important that is, but can you say anything about how to make it easier for caregivers to do those things and advocate for themselves?
It's a great question, and I'm not sure I know the answer. I try to do a lot of this passing on this information at the support groups that I facilitate. Mm-hmm. And a lot of the caregivers are under such stress that they don't think clearly. And when you point some of these options out that they have, it makes perfect sense to them, and all of a sudden it's like the light bulb came on. Mm-hmm. But they wouldn't think of it themselves because of the pressure they're under at the time. And a lot goes along with that feeling of being abandoned, and they're losing their friends and family members and all. So one of the answers, I think, is a support group, and another answer, I think, are the educational conferences that are available that helps turn the light on for a lot of the caregivers. I find it's kind of interesting. I've been looking at two different types of people in the support groups that I'm in specifically, and those with a law enforcement background and those with a military background tend, in a lot of ways, to act very differently than the average caregiver. It's much harder to get to them to agree to do things because they're basically take-charge people that like to be in control. Mm-hmm. They don't listen to advice too readily. But I find that kind of interesting to watch them.
Yeah. Well, do you find that they listen to you more than they would listen to somebody else because you have that shared experience?
Definitely. When they find out that you've walked the walk, then they're much more likely, although there's still some resistance there, but they're much more likely to, if you know what you're talking about, they're much more likely to listen to you.
Mm-hmm. Well, hopefully this will be a step towards, helping to educate more people, because clearly there's lots of work still to be done.
Any other questions, comments? If not, well, thanks to Anne and Russ for their wonderful presentations today, and thanks to all of you who had joined.
Nico?
Yes.
Hi, this
don't
is
forget Bob and
Oh, my God. We have a nice voice joining us.
Say how wonderful that this got launched, and what we're planning to do is get all of our support groups involved, and particularly our online support groups and others. So Julia Dillon has been on the full-time, and she directs our family support services. So we just think it's going to be a wonderful resource for people out here in the Southwest, but we know it'll be statewide as well.
Fantastic. Thank you so much.
And thank you, Nico, for making all this happen. This is very exciting.
Well, I try, as long as I can fix also the technical glitches that we've had today. But
you never know until you just jump in and
there you go.
Swim.
There you go. Many thanks to everyone, and as a reminder, we'll be posting the link for the file on allspossible.org, so you can download the file and view it, and it's free for all. We'll hope to see you again at our next sessions, and also if you have again ideas or comments or suggestions for the upcoming topics, feel free to email us. Thank you very much to all of you.
Thank you.
Thank you. Goodbye.
Thanks, Nico.
Bye-bye.
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 Bye.